Thank you very much, Joan. I too have been at this for more years than I'd like to admit, but I want to start by just thanking Joan for her leadership here at the medical school. Just have to look at this program that's unfolding over the course of the week to see what an incredible impact she and her office have on the entire Harvard Medical School community. So I just want to take a moment to ask you to join with me in thanking Joan for her great leadership. Really was excited to get this invitation from Joan and have an opportunity to spend a few minutes with you, sharing with you my thoughts about diversity, why it should be important to academic medical centers, and then share with you some of the journey that we've been on at MGH, trying to advance diversity on multiple fronts. In my mind, the most important reason why we should care about diversity and inclusion as academic medical centers is because of social justice, and I've felt this way for as many years I've been in this topic. Works for me, motivates me to pursue this issue. But I think given what this country has been through in the last 6 to 12 months, it's even more important than ever that we advance this issue. Hopefully more people within our institutions will understand the linkage between our efforts in this area and what's going on in the world around us. And so I'm hopeful for even more people that social justice will be a sufficient motivating force for advancing diversity at academic medical centers. But if that's not sufficient, I think there are at least 5 other reasons why we should care about this topic. The first is that I think there's growing evidence that diversity makes people and institutions better. We've had at MGH, I'm sure a number of you have been exposed to the work of Scott Page at the University of Michigan, an economist, and there's a growing science in this area that basically shows that the more diverse you have a group of people solving a problem, the better they do at solving the problem. And so I think you can make a direct linkage between diversity and the quality of our organizations. The other reason to pursue diversity are the demographic trends. I think we're putting ourselves out on a pretty flimsy limb as businesses in this society if we don't have a workforce that reflects the society that we will be serving now and into the future. And so I think the demographic trends are certainly a burning platform that should make us focus more on the issue of diversity. Then I think there are 3 specific activities that can go on within academic medical centers interested in diversity that enhance the range of services and activities that we can be engaged in. Health equity, and I'll show you some examples of that at MGH. Certainly we need as organizations to be advancing health equity, one of the 6 pillars of quality that the IOM identified, with the same vigor that we advance cost effectiveness or convenience or some of the other pillars. Educational, there's no doubt that if you learn in a diverse environment and have trainees that you're in a diverse group of trainees, there's great learning that comes from that. And so I think it enhances the educational experience for all trainees, that the more diverse our institutions are. And obviously there is a great opportunity to do research in this field to advance knowledge and our understanding and ability to combat disparities. So diversity adds to our research agenda in an important and powerful way. So there are at least six reasons I think that we should, as institutions, should care about diversity. Again, the first one that I showed on the previous slide is sufficient for me, but sometimes it takes this second slide to get other people over the threshold necessary to be enthusiastic about this topic. So I'm going to spend the rest of the talk just giving you some, again, sharing with you the journey at Mass General Hospital that we've been on. This is the mission statement of our hospital, which was adopted by the Board of Trustees about 5 years ago. And it speaks in more modern language to why the hospital was created over 200 years and what we've been up to ever since then. But I think there are a couple of clauses in it that are relatively distinctive. One is the first one, that the whole purpose of the mission statement, or the intro to it, is that we are guided by the needs of our patients and our families. That's really, in the end, what it's all about. But I think another aspect of this mission statement that we feel very strongly about is that it has 4 parts to it. There's clinical care in the second clause, there's research and education in the third, And then there's also serving the community, improving the health of the community, and it's not by accident that it says to improve the health and well-being of the diverse communities we serve. I inherited a diversity program from my predecessor, Jim Mongan, and I know some of you are in the fellowship program that is named in Jim's memory. But when he came to Mass General, probably in the early 90s, he established a diversity program. It was a topic that he cared very deeply about, and he organized it into three major components. One was our diversity efforts as it relates to patients. How do we, as an institution, enhance the services that we're providing to a diverse patient population? The second part of our diversity agenda was focused on the workforce. How do we attract, retain, and develop a diverse workforce? And the third focus of our diversity initiative is the community. How do we, as a large corporation within the city of Boston and this region, work collaboratively with the community that we are embedded within and develop positive relationships. This organization of our diversity efforts, which Jim established over, I guess now, 25 years ago, has stood the test of time. We still organize our efforts along these lines, and it's a tribute to him and his commitment to this field, but also his ability to organize management problems, complex management problems, in very simple ways. That these three pillars have stood the test of time. Over time, though, the way that we've organized ourselves to address diversity has changed. Thanks to the leadership of John Potts, who was the chief of medicine when I was a resident and a medical student, he established within the Department of Medicine an Office of Minority Professionals that went on to become a hospital-wide department called the Multicultural Affairs Office, and this past year was renamed the Center for Diversity and Inclusion, and as I'll mention later, it offers a full range of services to the hospitals, to the departments, related to diversity as it relates to our professional staff. A couple of years later, our patient care services, which includes nursing and all the other health professions, established its own diversity program. And then about 7 years later, our HR department established a diversity program as well. As far as patients go, dating back to 1995, we established a Center for Community Health Improvement. It had a different name back then, but it was charged with developing collaborative programs with the communities that we serve. And in the case of Mass General's, the communities we most intensely serve are Charlestown, Chelsea, and Revere. In 2003, and I'll get into this more, we added to our quality program as well as our diversity program a disparities committee that was charged with trying to identify disparities within our own clinical practices and then come up with proposals for how we might address them. And then a couple of years later, we established an applied research program, the Disparity Solution Center, led by Joe Betancourt, which has helped advance our efforts in this important area. In a few minutes, is that we, within our strategic plan, that we completed a few years ago, rededicated ourselves to doing even more in this arena. And among other things, we have now asked all of our department chairs to develop diversity action plans within their clinical and academic departments. So we now have at MGH a number of different central resources that are available to the organization as a whole, but also to the departments within the institution to help them advance diversity. And I won't list all of these. I've mentioned some of them, but there is quite a nice array of resources focused on this issue. And in our mind, diversity is much more than racial and ethnic diversity. As you'll see here, we have a major effort going on related to disabilities. We also have a major effort going on related to sexual preference as well, and other dimensions of diversity which aren't shown here. I'm very pleased that some leadership organizations, including one that I'm very involved with, the AAMC, has spoken eloquently about the need for organizations like academic medical centers to be involved in diversity, and both they and the National Institutes of Health call on this not to be a peripheral activity within our organizations, but a central part of our fabric, and we've certainly been working hard on that at MGH. These three ovals I'm not sure what shape is that at the bottom. Looks like a flattened house of some sort. But this was the distillation of the strategic plan that we developed over the last few years. And up in the top left, one important part of our strategy is to deliver the highest quality care to our patients while at the same time controlling healthcare costs. Up in the upper right, we want to continue to sustain and advance our academic mission and community missions. Thirdly, we need to strengthen our ability as an organization to deliver on items 1 and 2. And fourthly, we need to maintain our financial stability so that we can do these things not only this year, next year, but long into the future as well. Drilling into this oval a little bit further, we identified 4 strategies that we wanted to pursue in order to strengthen our organization. One was to better use data in our clinical research and educational missions. Another was to realize the full potential of our workforce. And the third, relevant to today's discussion, is expand our diversity and inclusion efforts. And I'll mention a few things that we're doing related to that. One of the things that we established was a diversity subcommittee of our General Executive Committee. GEC is the committee of the hospital that was charged by the Board of Trustees to manage the hospital on a day-to-day basis. We have a number of different subcommittees of the GEC, some focused on research, education. We thought it was, we really wanted to make diversity a central part of the fabric, that it should be part of the central governance structure of the hospital. So we have now have a diversity committee. I am the executive sponsor of it and attended along with the CEO of our physicians organization, who's now the head of partners, so we're searching for this position as we speak. The committee is actually chaired by one of our chiefs, Jim Brink, our chief of radiology, and one of our senior vice presidents, Jeanette Ives Erickson, our senior vice president for patient care services. And the other members include department chiefs, other senior vice presidents, and other key leaders who are responsible for some of our key programs. And as you can see, its goal is to set goals for the organization, identify institutional priorities, and make sure that we're vetting diversity and inclusion throughout our strategic effort. One area that we've been at for a while is trying to provide equitable care. And I credit Joe Betancourt, Joan Quinlan, Liz Mort, and others for really helping us move this needle significantly. This is a shot from our MGH website, our quality and safety website, and if you go to that today, you will see a whole bunch of quality indicators that are stratified by race and ethnicity. We've been doing this now probably for almost 10 years. We continue to update it, and we continue to produce reports on how we are doing vis-a-vis our quality metrics with respect to race and ethnicity. Whenever we find a significant variance, we examine it carefully, and more often than not try to identify, put in place a program aimed at trying to narrow or eliminate that disparity. Obviously, just what causes disparities is very complicated. I think in most cases, nobody knows, so we decided not to try to necessarily figure out what was causing the disparity, but put in place a program that was agnostic to what the cause was, but using sort of the same tools and techniques of quality improvement, high reliability organizations try to chip away at these disparities. The first disparity that we found was back in 2005. We found it in our Chelsea Health Center. White, our Spanish-speaking patients were getting colorectal screening 35% of the time. White patients at the same health center were getting colorectal screening 10% more frequently. So we were not pleased with this. This was a real eye-opener for our clinicians in the Chelsea Health Center, who thought that they were trying equally hard to provide colon cancer screening to both of these patient populations. So what was designed in collaboration with our Disparity Solutions Center and the Chelsea Health Center was a Navigator program initiated shortly after we found this disparity. We used a registry to identify individuals who hadn't been screened for colon cancer, used a Navigator to contact them, determine the key issues that needed to be done to assist in the process, and then also worked with our GI suite to make sure that appointments for this patient population were given the attention they needed. And we're very pleased over the coming years to see that both our white and Latino patients' rates of colonoscopy screening increased, And actually now it's the white patients who are facing a disparity, not Hispanic patients. So in most cases we've seen the same thing by shining a light on a topic, be it diabetic care or colon cancer screening, everybody does better. But in this particular case, the lines crossed, and now it is the white patients who are receiving less than optimal care. Obviously for both populations there's still a lot of room to move up here. 100% would be up here, so this journey is not over. But we were pleased that we were able to demonstrate that, that this disparity had gone away. We were honored, humbled, I think in large part as a result of this work on colon cancer and a couple of other conditions, to receive from the American Hospital Association its inaugural Equity of Care Award given to a hospital making progress on disparities and diversity. And the person, again, who deserves the credit is Joe Betancourt here, who had the tough job of going out to San Diego to pick up the award from the AHA. So turning to a topic that you're focused on during this session, building a diverse physician workforce, we've attacked this through a number of different stages in the process. And as I said earlier, this effort is coordinated by our Center for Diversity and Inclusion, and Elena Olson is here this afternoon, who heads up that center. We focus in particular within this center on underrepresented minorities, as underrepresented minorities in medicine, as defined by the AAMC, Blacks, Latino, Hispanic, including Brazilian, Native American, Hawaiian, and Alaskan Natives, and certain other categories of ethnicities that are underrepresented in medicine. As you all know, if you look at the U.S. Population, it's quite diverse, 72% white in 2010, 12% Black or African American, 16% Hispanic and Latino, and about a year later, the U.S. medical faculty, not nearly as diverse, with only 4% African American and 12% Latino or Hispanic. So clearly, some significant underrepresentation among U.S. medical faculty compared to the population as a whole. Now, if you look at the pipeline, obviously, this disparity is in the process of getting narrowed, but even if you look at the most recent cohort of graduates of American medical schools, there is still a significant difference from the population as a whole. So we have faced a significant pipeline challenge. This is a brief description of our Center for Diversity Inclusion. It does a number of different things, including providing to our students, trainees, and faculty resources to enhance their careers, connecting them to mentorship and funding opportunities, networking with peers in the wider hospital community, facilitating their pursuit of research in a number of different areas, channel their dedication to health equity, community outreach, and social justice efforts. I said there are a number of other parts of the organization focused on these issues, and this center helps direct people toward them, and then cultivate their development as outstanding clinicians or investigators. We have a number of different programs. I don't have time to go through all of them. I'm just going to share with you a subset. But for students, these are college students, medical students. We have an 8-week summer research program called the Srtp, Summer Research Training Program, I believe. For our residency, this office works with all 20 of our residency programs for the last 15 years, trying to work on recruitment of best underrepresented minority residents into our program. And then as far as faculty goes, the program that I'm going to share with you some information about is a Faculty Development Award that we've had in place for a number of years that provides annual awards to physician scientists or clinician educators. VCP was established in 1992 as a pipeline program for college students, medical students who were potentially interested in careers in biomedical research and medicine. It's supported by my office as well as our Executive Committee on Research and our physicians organization. And it focuses on college students in their last 2 years of their undergraduate studies, as well as first and second year medical students. So far, over the last 13 years, 220 students have come through this program. And each year we select about 15 students from, I think it's like 200 or so that apply, who are interested in pursuing this experience at our hospital. And what's very gratifying is that 98% of the alumni of this program have attended medical school. And this is a picture of some of the sessions involved. And what happens over the summer is it's a great opportunity for these students to network with each other as well as some of our trainees and staff. It's a great opportunity for them to get embedded in a laboratory and then have to present their research skills toward the end of the summer. And I've attended a number of those presentations, and not only are we providing great experiences for these students, but they are, in just a short couple of months, helping advance our research mission as well. The presentations are quite impressive. On the residency recruitment front, this is the 15th year that we've been, this office has worked with all of our training programs to strategize and ensure that we are attracting best trainees. Every fall, and it's sort of like a rite of fall. I attend this meeting every fall. We get together with all the program directors, their administrative assistants, and talk about the schedule, the process we're going to follow for the year ahead. There are 10 different receptions that our this Center for Diversity and Inclusion organizes that our underrepresented minority applicants are invited to when they're at the hospital for their interviews. The staff of this office serve as program consultants to our training programs, advise them about how to conduct their activities to attract people. We have in several departments applicants who are invited back for a revisit day and also a gala that a number of our faculty and leadership attends. And then we look and see what, once the match is over, what happened. Where did people go? We get a reasonable share of the people that we're interested in, but people do choose to go elsewhere. And so we actually formally survey those residents, or those students, graduating students, who could have matched with us had they ranked us high enough, but decided to go elsewhere. And we survey them to try to understand why they chose to go elsewhere. Say the single biggest reason they go elsewhere is location. Boston's pretty expensive, but unfortunately it doesn't, in some people's mind, enjoy a great reputation for among underrepresented minorities. And family is a big issue. People have families in other parts of the country, want to be with family, so we're trying to come up with a drug that maybe does something to make people care a little less about family. I'm obviously and then there are certainly some students who just feel that the training opportunity in a particular program or a particular institution was better. But Boston and location is by far the biggest issue that we face. The Minority Faculty Development Awards is a program focused on our faculty, aimed at trying to build a more diverse workforce of clinicians and investigators. We want to enhance the academic careers of some of our junior faculty and increase the number of our underrepresented faculty by doing a better job of retention. So every year we offer 2 Physician Scientist Development Awards and 1 Clinician Teacher Award. I think we've given 26 over the years. These are funded by my office, by our physicians organization, by our executive committee on research. As a person in the Department of Medicine, I'm pleased to see that medicine is sort of cleaned up as far as these awards go, but other departments have also had recipients as well. And what's very gratifying is that of the 14 Physician Scientist Awards that we've given over the years, 13 of those recipients are still at the MGH, 93% retention rate. And if you look at the people who applied for these awards but didn't get them, their retention rate is only 57%. The same is true for our Clinician Teacher Awards, 83% retention rate, and a lower rate for those who didn't receive the awards. So these clearly are a very potent retention device. What's also amazing is that we've spent about a little over $3 million on this program to support these 26 grantees. The research that they've brought in now totals over $23 million. So that to the extent that you can make a return on investment in research, which is really impossible, we've realized that's a very significant return on investment. And we're in the process of publishing a manuscript on the outcomes of what we think has been a very successful program over the last decade. And then I guess the most recent chapter in our diversity effort I wanted to share with you are these diversity action plans. I think as we were working on the predecessor of our hospital-wide diversity committee over the years, we realized that the rubber really meets the road when it comes to diversity in our clinical and academic departments, like medicine, surgery, and others, et cetera. And so we came up with the idea coming out of this strategic planning process that we wanted to encourage, or maybe more strongly put, require that each department come up with its own plan for how it was going to advance diversity within its midst. And so currently, our Center for Diversity and Inclusion brings together the diversity leaders from all of our departments so that they can learn from one another about the strategies that they are pursuing. And the diversity action plans of the departments include a variety of different things, but they have certain generic qualities. A lot of them, almost all of them, focus on recruitment of trainees, fellows, and staff, retention and engagement, training and education and diversity, not only for the professional staff, but for everyone who works in the department. A number of the departments have focused on how the physicians and the rest of the staff can work more constructively with one another. A lot of focus on cross-cultural education, and a lot of focus within the diversity efforts within the department on community service and outreach. So all 19 of our departments at this point have developed a plan, or in the process, well along in the process of developing a plan. 13 of our departments now have their own diversity committee. 10 of those are multidisciplinary. They include not only physicians, but nurses and other staff within the department. 3 of them are faculty only. And 10 of these committees are either chaired by the chief or have the chief who sits on them. And I think that makes a big statement about the importance of this effort within the department. And then every year I meet with Elena and the chief and the chair of the diversity committee within each department to get an update on their activities and understand what they are focused on. Every year, the head of the physicians organization and I do a performance appraisal of our service chiefs, and we put together for that a balanced scorecard of how they're doing on their clinical activities, their research activities, a full range of activities. And one of the important things on that balanced scorecard is their diversity action plan and what it consists of and how well that effort is moving along. So we are trying to establish accountability, responsibility throughout the organization. So I guess I would close by just saying that this effort, which I've now been engaged in since Jim Ongen kicked it off in the early 90s, is clearly a marathon. It is not a sprint. We put an enormous amount of effort into this effort. I think on a day-to-day basis, sometimes it can get frustrating. You don't see evidence of progress, although I'm pleased when you step back and look over the course of years, there is clearly progress. I think it's critical that leadership at all levels be supportive of this. I've never encountered active resistance to this effort, but I have certainly seen variable degrees of enthusiasm for this effort. And so that accountability process that I described, I think, helps increase some enthusiasm. I think it's really important that there needs to be some central infrastructure, some central resources that the departments can call upon to move the effort ahead. But like I said earlier, this work really needs to be embedded within the departments themselves, because it's the departments that are recruiting, retaining physicians, and actually conducting the 4 missions of the hospital. I think it's also quite clear that we need to start early in this process. The biggest obstacle to enhancing diversity in medical workforce is not our residency recruitment efforts, it's the pipeline. It's the choices that young people are making at a much earlier stage in their career to go into medicine and do something else, or whether they have the opportunity to go into medicine. As Joan said, I currently chair the board of the LANC, and at our Council of Deans meeting just about 2 months ago, some pretty startling information was presented by Valerie Rice Montgomery, who's a dean of a medical school, who analyzed some of our MCAT data. Turns out that if you look at white men who take the MCAT, 74% of them apply to medical school. If you look at black men, only 46% who take the MCAT actually apply. for reasons that I don't fully understand, and the AAC doesn't fully understand, but is certainly analyzing, there's just a much bigger drop-off of people, of black men interested in medicine, who take the MCAT, and then for one reason or another decide not to apply. So that may be a significant opportunity for Harvard institutions and others as well. And I guess the final thing I would just mention is that I'm a strong believer that if you don't measure something, you can't manage it. That's true in all aspects of what we do. It's also true in diversity. And so I think it's really important that we have measurement systems in place to look at how we're doing on disparities, to look at how we're doing on enhancing the diversity of our workforce. So I want to thank you for your attention. I think we have about 10 minutes to address any comments or questions that you might have. Thank you.
More about your CDI, this career development initiative, which you're providing extra resources on the improved faculty at MGH. Do you have individual departments for this school, or do you, how does that work?
You're referring to the Career Development Award? No, individuals apply. And then we have committees that choose the most meritorious applicants. One committee for the physician scientist, another for the clinician teacher. And it's a highly competitive process. And so it's a merit-based system that ultimately determines who gets chosen. Certainly one important part of the application is a letter of support from your department chair. And those are often helpful in demonstrating, well, in speaking to the virtues of the applicants, but also demonstrating the strength of departmental support for the applicants as well. Yes, Gerald.
I have a question about the accountability board. And I think for lots of organizations, we talk about the importance of diversity and the expectation of majority diversity. And then there's really no accountability put into place. And wanted to know how you were able to set a tone for this in terms of this work. For people to be able to take it back to their own institutions in terms of fostering an environment for both building the evidence and the knowledge, but also accountability.
I mean, this is definitely an evolutionary process. I mean, when I started my job, well, I guess when I started as head of the physicians organization, now almost 20 years ago, there was almost no accountability process for the chiefs. There was no annual performance evaluation. They were appointed by the trustees and then basically went along their merry way. And working with Jim Ongen, we put in place an annual performance evaluation session, which I think started off pretty informally because it created a fair amount of culture shock for the chiefs. But over time has become much more serious. And one of the things that we did early on was to put in place this balanced scorecard. And I think just determining what's on the scorecard is very important, because these chiefs, like lots of people across these Harvard institutions, are type A personalities. They want to get 100 on their report card. And so just having quality measures, having measures of turnover among the physician staff, having measures of research grant funding and the progress that it's making within the department, but now having information about their departmental diversity plan. I think that in and of itself, independent of what is actually said at those meetings or what consequences it had, I think that's an important statement and gets people to focus on that. But we do, at some of those meetings, either give people a lot of praise for really being leaders in this field, or something, I guess that's at the other end of the continuum of praise, and then trying to encourage people to do even more. And I think I mentioned earlier that again, I haven't seen any active resistance to these efforts, but I guess I would say that the enthusiasm tighter for it is up significantly over what it was 15 years ago when we started, and I think some of that is related to turnover, but I think some of it is related to just getting people to focus on it. Yes?
On a personal level, I wonder if you've changed hearts, if for people who were not interested in this, over time, thinking it, kind of doing it as a fixing to it? Was there a process on which they were doing this and beginning to care? Because I'll give you a context. So I came into the fellowship here. One of the things that I will never forget is in Kennedy School, Kathy Eden saying, as a sociologist, one of the hardest things you had to learn was to advocate, to not be a scientist. Personally, we were becoming an advocate, to actually have a community. And when I look at around the country, barriers to actually doing this work, they're emotional, they're personal, a lot of white men aren't accustomed to dealing with the issues, having to actually change that. And so you haven't documented kind of this personal change, transformation. It might be interesting to have some documentation, but I wonder just, if you noticed the process of how people have gone through this process.
Yeah, I mean, it's hard to measure people's hearts and where they start out when exposed to this. But I would say that there's nothing that breeds success like success. So when we started the revisit program for students that we were particularly interested in, I think that started in the Department of Medicine. The yield among those students shot up dramatically, and other departments saw that and decided to jump on board. I think early on when we started these departmental action plans, a number of departments were scratching their heads as to what they were supposed to do. But then some of our chiefs, like David Lewis in pathology, Isaac Schiff in OBGYN, really put together these committees that developed a robust agenda, seemed to gain a lot of momentum within the departments. They had faculty members who came to our chiefs meeting speaking enthusiastically about what was going on. And I think that made the other chiefs realize that there really was something they could do and that it could help enhance the overall strength of their department. So it does take some innovators who are willing to take some, who are fully committed and willing to take some chances to demonstrate to their peers that I mean, it's maybe awkward, maybe uncomfortable for some people, but it's no different than trying to improve quality or productivity or the other things that we expect our chiefs to do within our departments. They don't necessarily have to personally play the lead. They just need to set it, provide the resources, provide the leadership to others to do so. Yes, right here.
On the point of acknowledging the outcomes, I was sitting making some notes about your involvement with our CPSA program. And just rough notes, we have 6 new mentors who are working with us this summer. We have 3 fellows, MGH fellows. We have the first new resident coming to MGH when we started in our college program on leading community medicine and pediatrics. And Judge, who was a long-term judge for us, so I'll send you this later on, but it didn't occur to me until you mentioned it that this would be something that is equally useful for us as well as you.
Yes, Joe?
So it's a slightly different kind of question, but maybe you could speak, and this is from your hat within AAMC as chair of the board. We talked about part of the importance of the pipeline programs and talked about the work that's being done to bring people into residency. And maybe you could speak a little bit about some of the conversation about graduate medical education, about potential goals to do, or how we're thinking about boards. This partly is an obstacle for some of the bringing in some of the universities before in terms of thinking about the USMLE and those tests. The same way that we thought about impacts or SATs, a number tells you something as opposed to, it tells you something but doesn't tell you everything about candidates. But it's important to think about the whole person.
Well, I think the WMC, well, as you know, the WMC has changed the MCAT. It's now, the new version is just being administered as of last month. I think the hope is that it will do a better job than the previous test, identifying better rounded students with knowledge and interest in the social sciences, but only time will tell what impact it has on diversity. I think the data that I described earlier, I mean, it would be unfortunate the MCAT is making progress in diversity worse rather than better, and I think it's something that the organization needs to look very seriously at. One big difference between medical training now compared to when I went through it is how much time and energy is spent on the licensing tests. If I had my druthers, and I think if the AANC had its druthers, they would be pass-fail. The amount of time that students here and other schools around this country are spending studying for the test is unbelievable. And unfortunately, in some residency programs, it is used as a screen that separates those who have a chance of getting an interview from those who don't. And I don't think there's a whole lot of evidence to suggest that better scores above a certain level on the licensing tests are predictive of better positions. So that I think is a very worrisome development. So I hope that addresses some of the.
It does. I think the major part of it for me is for people to understand that those kinds of challenges are continuing. And I think that the licensing exam has actually been raised in terms of how people are, that they've had more applications coming in and use of technology. So looking for several ways to screen individuals and they're using a number.
And another unfortunate trend that we're seeing in AANC is the number of programs that trainees, well, both medical schools and training programs that people are applying to. As it becomes more competitive, particularly on the residency side, one response by people is just to apply to dozens of programs. It's crazy. And good news from the AANC standpoint is that we get more money for every initial program that somebody applies to. But that also is causing training programs to be overwhelmed with the number of applicants and having to rely on these mind-numbing tools like board scores to decide who to interview or not. All right, one final question that I need to
chairs of admissions committees, the chairs of promotion, board of directors of centers, just because you're really on
Yeah.
I haven't seen much attention around that.
Yeah, no, I know the organization would celebrate that development. I don't know that it has specific, I mean, it has a major diversity effort of its own and through Mark DeVay's efforts, provides lots of resources to medical schools, teaching hospitals around the country. But I don't know that it addresses that precise issue directly. All right, well, I hope you enjoy the rest of your program.